Hello, and welcome to the Rural Doctors Association of Australia's annual Politicians' Address. We apologise for the technical interruptions to our live and interactive version of this event, and we thank you for taking the time to listen to it online now. We acknowledge the traditional owners of the land on which we all meet and pay respects to elders past, present and emerging. Before handing over to our President, Dr. Megan Belot, we invite the Honourable David Gillespie, Minister for Regional and Rural Health, to address the meeting. Thank you, Minister.
Hi, I'm sorry that technology prevented me from participating in the Rural Doctors Forum this week. I would first of all like to acknowledge your hard work and dedication and all the care you've delivered to your patients and the community during the COVID-19 pandemic. You've all gone above and beyond what any reasonable practice would do. The nation owes you a great debt of gratitude. I'd also like to thank all the great work that I've been able to achieve, well informed from the advice, policy insight and experience of the Rural Doctors Association. It's a great pleasure to work with your representatives, Peter and Megan, and before that Peter and John. You've got a sterling team and they are great to work with. They're tough, smart advocates. There's no nonsense with Peter in particular. And there are not a lot of organisations that are as trusted in Canberra as the Rural Doctors Association of Australia. There is also the reality that we have a federal election coming up. It's only a couple of months to go before we'll be back at the polls. And we can go to the polls knowing full well we have delivered an enormous amount of great policy and great outcomes for rural doctors and the whole rural health space. We've got 16,000 students trained through the Rural Health Multidisciplinary Training Program. We've established the 5 rurally based end-to-end med schools through the Murray-Darling Medical School Network. The facts speak for themselves. There are 750 new doctors registered in modified Monash 2 to 7 since the Stronger Rural Health Package was delivered. We've got more than 1,000 nurses registered newly in those areas. We also have transformed 140 international medical graduates through the More Doctors for Rural Australia program. We've got the Rural Junior Doctor Training Innovation Fund, getting PGY 1s and 2s and 3s out into rural general practice so they're not caught in the specialist rabbit hole inside big teaching hospitals. We've got more than 8,000 doctors and 5,600 practices that are now involved in receiving workforce incentive payments. There's plenty more to do. As you know, I've announced the HECS Help Debt Relief for doctors going forward in their 4th postgraduate year in modified Monash 3 to 7 areas. We want them to stay, and at tipping points in their career, I'm sure this able to have their help debt relief will shift more to continue practicing rurally. I'd like to thank you again. You've done a great job for the nation. You've got great advocates in Canberra, and I look forward to working further with the Rural Doctors Association.
Thank you, Minister, for that address and for the time and effort you put into your portfolio. It makes a real difference to rural doctors right across Australia. And now to hand over to RDAA President, Dr. Megan Belot.
Good afternoon. I'm on Ngunnawal country and would like to acknowledge the traditional owners of the land on all the lands which we meet right across Australia, and pay my respects to their elders past, present and emerging, and all Aboriginal and Torres Strait Islander people who may be listening to this address. I'd like to extend my respects to the Warlpiri people of Largermanu and Kalkarinji, where I spent time as a medical student and junior doctor and was a huge influence on my training and decision to be a rural generalist. Thank you for coming. We are so disappointed not to be able to meet in person, but I hope I can provide you with some insight into the challenges being faced by rural doctors and give you some thoughts on how they can be addressed. After my presentation, there'll be an opportunity to go into some virtual meeting rooms to talk to some of the leading doctors from your state. We really encourage you to take this opportunity to discuss policy and how it affects us and our practice. Last year, RDAA celebrated its 30-year anniversary, and as part of that, we have invited all of our past presidents, many of whom are here and keen to talk to you. This is a rare opportunity, and we hope that you take advantage of it. It's a bit daunting to presenting not only to so many of our elected representatives, but also to these legend past presidents. It wasn't that long ago I would never have anticipated stepping into such a prestigious leadership role and into an enormous honour, and it is an enormous honour for me to represent our profession in this way. While there hasn't been a female RDAA president for a while, I follow in the footsteps of a number of great women who have taken on this role over RDAA's 30-year history, including the wonderful Dr. Nola Maxwell, who I know is online today. RDAA has achieved board equality between male and female representation with no direction or quota. This is a reflection of the equality found in the field of rural medicine, where the skills and the leadership of the individuals are considered without reference to gender. To tell you a bit about myself, I am a dual-trained rural generalist and doing GP work in Kerrang as well as anaesthetic VMO work in Kahuna and Echuca hospitals in country Victoria. I did the entire training of both ACRM and ROCGP. I completed my internship at Box Hill Hospital with my first rotation to Bairnsdale. I remember my final medical student supervisor giving me their personal mobile number in case I needed support, as I told that I'd be left to my own devices and it can get pretty wild down there. I definitely saw what it was to be a rural generalist, and this did inspire me. And you'll be glad to know that I didn't need to use my supervisor's number either. It still wasn't enough to know what I truly wanted to do. I went to Darwin for my junior doctor years and residency, where I did the amazing PG Triple P program out to Larjumanu and spent a fair bit of time in Katherine. At this point, I was thinking about actually being a surgeon, but I didn't quite like the 3-hour operations and I really missed the other parts of medicine. So I took 2 years off and I locumed to remote places like Christmas Island in a detention centre, more time back in Katherine, rural New South Wales and Tasmania. It wasn't until I was locuming in the town of Echuca on the Murray for the infamous ski speed race weekend of the Southern 80 that there would be an intervention. I met long-standing rural generalist Dr. Sue Harrison, who is still one of my mentors today. Sue asked me what I was doing with my life, and I said I was thinking about being a rural generalist and would love to do anaesthetics, but I just wasn't quite sure. Well, 1 month later, I was doing my advanced skill in anaesthetics in Bendigo. I can't stress to you the importance of someone taking that interest into my rural career pathway was. Supervisors and mentors are so important, and they need to be valued and respected and paid accordingly. Following this, my first rotation for GP training was in Echuca with consolidation of my anaesthetics that year, and my final GP training term was with the Royal Flying Doctors in Broken Hill doing a combination of outreach, GP clinics and retrieval medicine. Insight into my working week currently, recently I've actually recovered from COVID, and when I went back to work, of course, I was covering for other doctors who were on leave because of COVID. And so just to give you an example, so on Thursday I did a GP full day in Kerrang. Friday was followed by anaesthetics back in Echuca, working with the orthopaedic surgeon, doing hip and knee replacements. Saturday, Sunday, Monday was doing ward rounds in Echuca Hospital, which luckily only went to lunchtime and didn't blow out to 2 p.m, which sometimes they can. And then Tuesday and Wednesday we're back doing GP work in Kerrang. And on top of all of that, I also do on-call in Kahuna for their anaesthetics 24/7. So I also run a beef cattle farm with my husband Mick, and we have a 2-year-old son. And we are very committed to making our lives in a rural area. Not necessarily Victoria, we're interested in Queensland and South Australia, so who knows, as long as there's enough cattle and livestock, and that's Mick's requirement. My requirement is that there's enough water, preferably rain, although irrigation water could work too, so long as as long as the price is viable, because currently in the district we live in, this is a real stressful issue for our farmers, and it's important that you have a viable farm. So keeping my husband happy is really important for me to stay rural, and the doctor's partner plays an important part in the choice of going rural. That's why RDAA has been working on a proposal to encourage opportunities for partners' employment, with incentives for businesses to employ the partners of critical workers, not just doctors, but other professionals who are vital to the economic viability of rural communities, such as teachers, executive level managers, police officers, and senior experienced nurses. Partner employment is a huge barrier to many moves for rural doctors, and anything we can do to help address this workforce barrier should be put on the table. Okay, right, let's talk medical workforce for rural. There are 4 points to where medical workforce is lacking. 1 is rural generalist, 2 is rural GP, 3 is rural consultant specialist, and 4 is doctors in training. And can people please put their thing on mute? Just added that in. So, right, let's talk rural generalism. The recognition of rural generalism as a specialty is a long and arduous process that is currently underway, with ACRM doing a huge amount of work in this space. This recognition will be key to providing both the fair and equitable remuneration for services provided by rural generalists, but we hope will also attract even younger doctors into a rural career pathway. Having it recognised as a subspecialty of general practice will help us address this problem. This recognition will also help consultant specialists to recognise the value of the RG workforce and use them to their best advantage. Rural generalism needs to grow, and having done training in both colleges, ACRM was the college that gave me all the tools I needed to succeed as an RG. ACRM's training is robust and it is longer for a reason. ACRM only holds, though, 10% of AGPT training positions, yet 80% of their fellows remain in the rural remote at the 5-year mark and 75% at the 10-year mark. It is quite clear to me that ACRM need more AGPT training positions, as they are limited by this currently. We need the Rural Generalist program to be moving nationally and maintain the core values of the Rural Generalist. We need this to be a robust program to make sure advanced skills are not only maintained, respected and paid well. We need the full program to be rolled out, including WIP reform that recognises not only rurality of place of work, but recognition of service provision such as after-hours emergencies, and also the areas of advanced clinical skill which aligns with the needs of the community. We are seeing more and more doctors training as GPs, not wanting to take anything outside of the 9 to 5 general practice, but our rural communities need and deserve more. It is important to also acknowledge that working in the hospitals the whole time as an RG isn't always the answer too. An RG who works across both the hospital and the general practice is what a lot of our rural communities need. Also, working alongside the RGs that are in the hospital and the rural GPs that are in their private practice too. Okay, so second point is rural GPs. Whilst it's extremely important to look at the progression of RG, we must acknowledge the great work our rural GPs do in their private practice who may not work at the local hospital. It isn't my cup of tea, and most of the time they have very complex patients and a variety of patients they see working full-time as a GP. I simply cannot work like this. I need more variety, and I really take my hats off to these doctors. GP training is undersubscribed in general, and this needs to be addressed. Medicare freeze has killed GP, especially in the wake of the upcoming doctors who are much more educated around leave entitlements like long service leave, annual leave, education leave and parental leave. And yes, I've used the term parental leave. I have not used the term maternity leave. The GP world cannot compete in comparison to the hospital specialists. RDAA keep asking to lift the rebates, and we have been lucky the rural rebate for bulk billing is now with us, but realistically we need more. So we need to look at new models and we need to look at new ways forward. It takes a lot of years to get here and also a lot of ongoing training, and I do make a good living as an RG. I am the primary income earner for my family, but I don't earn enough to be able to take a long period off work and have no income. Parental leave for GPs and rural generalists is basically non-existent. We need a policy that recognises the primary caregiver and we need a policy that recognises the primary caregiver and major breadwinner in the family may be the birthing mother. Society is changing, work-life balance is changing, and this needs to be acknowledged. Parental leave should be paid. It must be acknowledged that if you are a female earning over $150,000 annually, and let's say your partner earns $40,000, you get no paid leave by the government. But if I'm the mother and I earn $40,000 and my husband earns $1 million, I get paid the parental leave. This is outrageous. And for me, this means my son isn't getting a much wanted brother or sister anytime soon. The lack of entitlements and things like paid parental leave is a significant barrier to attracting junior doctors to general practice. The move to college-led training is an area in which RDAA have been heavily involved, and we are a vocal lobby voice to ensure that the policy behind it is right. We strongly believe that professional-led training is in the best interests of GP training, and it also needs to be in the best interests of rural generalist training too. There is an opportunity here to be a little bit brave and to ensure the rural communities have doctors with the skills to provide the services they need. The devil will be in the detail to make sure it is rolled out appropriately, and I'll be very keen to see that a close eye is kept on this to ensure the better outcome for rural, so we can start addressing the massive maldistribution of GPs in Australia and get a better outcome for the bush and paid parental leave. We need to keep GP training programs simple, flexible, and keep listening to the trainees. On a positive note, around helping rural GPs and rural generalists, telehealth has helped enormously. Already in my presidency, I have seen policy that where driven by the professions becomes a reality. Telehealth has been such a critical part of the health response to COVID-19 pandemic, and the real win is that the policy setting for permanent telehealth is now in place. RDAA has always been strong advocate to telehealth and often raising the issue when many weren't interested. While it's not completely perfect, if you had told us 3 years ago that all Australians, we would have GP to patient telehealth funded, including video and telehealth, the celebration would have been huge. And I'd like to thank the Minister for Health, Greg Hunt, for listening to the profession and introducing a telehealth model that will have ongoing benefit to patients. Okay, third point, rural consultant specialists. Rural areas are chronically undersupply for non-GP specialists or consultant specialists, and we need to find ways to improve this access, whether that be by attracting them to the area, attracting them to provide outreach services, or using other technologies such as telehealth to minimise the travel imposed on our patients that costs them both financially and in their poorer health outcomes. It is exciting to see a significant expansion of telehealth consults with consultant specialists, which have gone from 1% to 14%. We need to work to ensure that rural communities get a balance that links telehealth to face-to-face within the community, because face-to-face care is still gold standard. For an example, I have a patient who needs to see a paediatric psychiatrist, but due to their anxiety, they don't want to see them via telehealth. Now, and this needs to be respected. Now, to get a paediatric psychiatrist in Australia is pretty tough at the moment. It's even tougher to find someone rurally. But the solution here would be to have an outreach clinic for a face-to-face consult, and then maybe perhaps down the line this patient maybe feel comfortable to then do telehealth with this consultant specialist. What is really important to understand is that there needs to be collaboration. Consultant specialist model isn't by itself to have in the bush is not necessarily better over rural generalists or GPs, and nor does it work the other way. So one specialty isn't better than the other. What we need to do is we need all the doctors to work together. There can be some fantastic models of care where the consultant specialist works together with the rural generalist who has an advanced skill in the same field. To give you an example, previously in Echuca, we've had a paediatrician who's worked alongside a rural generalist with advanced skill in paediatrics. Now, Echuca does serve as a decent area right up to Deniliquin or north, further north, all the way over to Swan Hill, all the way over to Shepparton, and then down to Bendigo. Like, it is a decent area. And the reality is that to get into a paediatrician, either in Bendigo or Shepparton, even if you want to pay privately, takes forever. Like, it takes months. So this program was implemented for the paediatrician to be in Echuca, and this RG would be able to see patients and work them up to a certain level and then link them in with the paediatrician or get advice from the paediatrician, then continue treatment. And what this enables is that the paediatrician gets to see the more complex cases, but it also helps with the load, because when you go to an area as the one rural consultant specialist, you get overloaded and therefore you get burnt out and you leave. And we've seen this happen. The issue with this model is that the way that it's funded. And so unfortunately we don't have that model in Echuca anymore. But there needs to be models where the consultant specialist and the rural generalist can work together. Okay, fourth point. Lastly, in the medical workforce, we need to talk about junior doctors. We need more of them to experience rural medicine. This is why RDAA is so strong on pushing the need to double the junior doctor investment into the John Flynn Provocational Doctor Program. We need to expose more junior doctors to rural practice, not just GPs, but also specialists in rural hospitals. Maybe they'll turn out to be the specialist who's happy to do outreach into the communities they fell in love with. This would be an excellent outcome. Doubling this program to 400 full-time equivalents would enable 1,600 junior doctors to have a rural experience, but also provide immediate increase to the workforce in our rural and remote communities. Something that affects all doctors, which is holding rural medicine back, is credentialing. We need national credentialing. 12 years ago, we finally got national registration, and I remember it clearly because I'd moved from Victoria, I kept my registration in Victoria, but went up to the Northern Territory and had to register again. And then finally when I returned back to Victoria, it was national. So simple. National credentialing, it just needs to happen. The ridiculous amount of red tape that hospital doctors, both rural and city-based, have to wade through in order to be able to provide our services into the areas that need them is out of control. For rural, the credentialing process are cumbersome, It can limit our scope of practice, and it prevents us from working in more locations, which reduces the services to many rural areas, and it creates shortages in hospitals where there really shouldn't be. There needs to be a centralised repository where current credentialing information is kept, enabling health services to access the information as needed for their recruitment and reduce the duplication of administration processes on the frontline doctors. But as we head into budget and election, it must be understood the issues and challenges of access to medical and other health services for Australia living in rural and remote Australia prior to the pandemic still exist. If anything, the pandemic has only put further stress on an already undersupplied workforce. The money spent on COVID cannot be considered an investment into rural health in the medium to long term. So in summary, we need the rollout of the Rural Generalist Program to train more RGs. We need college-led training to work to train more rural GPs. We need more junior doctors to have experiences in rural communities so that they come back to the bush in any capacity they would like. And we need more consultant specialists to provide face-to-face care in collaboration with telehealth, but also the rural generalist or rural GP on the ground. I want to thank all the people here that have contributed to the successes of rural medicine that RDAA have worked really hard on. And I hope that we can continue to work on them to make sure that it's even better. It's time for me to wrap up, so please join us in our virtual rooms, which are named by state, where you'll get to talk to past presidents, board members, state presidents, and some other invited guests. I would also like to acknowledge and thank the politicians I've met with in the last couple of days. Assistant Shadow Minister, Health Minister, Jed Kearney, thank you for listening, and we look forward to working with you to continue to develop the Labor health policy to align with rural and remote priorities and needs. Minister for Regional Health, David Gillespie, we can see that you get it, and we hope the government supports your ideas. Finally, I'd like to acknowledge and thank Minister for Health, Greg Hunt. I appreciate your immediate support and engagement you have given me as the RDAA President. I thank you for making GP to patient telehealth a reality. You only have a couple of months to go, so please be brave and make some tough decisions, not necessarily because they're popular, but because they're the right thing to do for rural. We thank you for your service as Minister for Health. I'm looking forward to my next 2 years advocating on behalf of rural medicine, and I hope to be able to meet more of you in person next time I'm in Canberra or at our annual conference, Rural Medicine Australia, which will also be held in Canberra this year in October. Thank you.
Thanks, Megan, for that great address. And thank you all for listening online today. If you'd like to reach out to the organisation to discuss any issues heard here today or any other issues affecting rural and regional health, please don't hesitate to contact our CEO, Peter Rutherford, at ceo@rdaa.com.au, or other contacts are available on our website, rdaa.com.au.